guys, let's start with today's session. Okay, so Dr. Ujjwala, I'll request you to share your screen and start with today's proceeding. And to others, please, I'll request mute your mic so that it will be clear for everybody. Okay. Any questions that we'll take at a later stage so that we complete this presentation with, I'll say 10, like till 10. Okay. And one more thing, I'll request anybody of you can note down the questions which are there, any questions, any Viva discussion points, so that we can discuss them in the upcoming day, tomorrow, day after, and day after tomorrow, so that we can complete it, the whole history, examination, and the discussion part. Okay, so Dr. Ujjwala, please share your screen. I'll mute myself, and I'll keep on interrupting you in between as we progress ahead with the case. Please don't mind my words. Okay, let's go ahead.
Yes, sir. We'll share my screen. Thank you for the opportunity, sir. So, is it visible, sir?
Yeah, go ahead.
Yes, sir. Okay, sir, I'll present like this. So, a 38-year-old male named Subbarao came to ENT OPD from Nuzivedu, Andhra Pradesh with chief complaints of right ear discharge since 1 year. Right ear hard of hearing since 6 months. History of present illness. Patient was apparently normal until 1 year back when he developed right ear discharge, which is insidious in onset, continuous, greenish in color, sometimes blood stained. It is scanty, thick, and associated and foul smelling. There are no aggravating factors. It is relieved on medication. History of right ear hard of hearing since 6 months, which is insidious in onset, progressive in nature. Especially, he even cannot hear whispered sounds. There is history of right ear ringing sensation, which is insidious in onset, progressive. It is continuous throughout the day. It is hissing type.
Dr. Ujjwala, I would like to stop you over here. Okay, see, whenever you say something in the Viva, you start inviting questions for yourself. And as far as I had seen through the last 5 years, tinnitus remains one of the topics which is a little bit problematic. Okay, so you speak of tinnitus, your Viva will go on tinnitus rather than going through the routine Viva on COM's comments. Getting my point? So as a advice, see, nobody is going to ask the patient and tell you that what are your complaints. And as far as this discussion is concerned, we are going through the sole aim of clearing that practical exam on this condition. I'm not dealing with all that academic excellence and all. The main thing is we should be able to answer on that Viva day. So my request is this cheez ko you should skip it out rather than inviting some unexpected questions. Getting my point?
Okay,
so move ahead.
Okay, sir. There is no history of ear pain or reading sensation. There is no history of facial asymmetry, fever and headache. There is no history of nausea, vomiting. No history of neck pain and stiffness.
Dr. Ujjwala, till now, whatever history you have given, what do you think what it is? It is what kind of disease it is?
Till the history taken, it appears to be a chronic otitis media, probably aticoantral type.
Why aticoantral type? Why not tubotympanic? Till now, only on history basis.
It might be aticoantral because of the color of the discharge, even the quantity, that is scanty in color, associated with foul smell and thick in consistency.
Okay, and why is this the discharge you are saying? Why is it scanty and foul smelling in your aticoantral?
It is scanty because of less mucosal glands in the attic region. Foul smelling because of the bone eroding property, that is osteitis by the cholesteatoma.
It is 50% correct. I would like to reframe your answer. Like if somebody asks you that why is the discharge profuse in mucosal type, so your answer should be that the middle ear is rich in mucosal glands, because of which there is like profuse discharge, and this is the nature of discharge. But when the question is regarding the aticoantral type, that is the squamous type, your answer should be that due to the relentless osteitis which is taking place, the discharge is scanty. Okay?
Okay, sir. Okay, sir.
Moving ahead.
There is no history of nasal obstruction, nasal discharge. There is no history of throat pain and difficulty in swallowing.
Okay, just a minute. Please go to the previous slide. Okay, so you have taken history of fever and headache. What are you thinking when you are taking history of fever? What is the importance of fever in a CM case?
Fever here may be due to the meningitis or abscess like extradural abscess, subdural abscess or brain abscess. Impending to intracranial complications, we are taking fever and headache.
Okay, so you are basically taking history of some complications because of which you are asking the fever. Okay.
Sir.
And in meningitis, what are the two other common signs which are commonly seen? Just name them.
Brudzinski sign and Karnick sign.
Great. And fever is also there in lateral sinus thrombophlebitis, right?
Oh, yes, sir. Yes, sir. Yes, sir.
What kind of fever is there? What is that typical description of that fever?
Picket fence fever.
Lovely. Move ahead.
Yes, sir. Past history. No history of similar complaints in the past. He is a known diabetic since 5 years on medication which is under control. He is not a known hypertensive, not an epileptic or asthma or bleeding disorders. He underwent hydrocele surgery 18 years back. Sir, here also, do you suggest, sir, that we should not mention the asthma, epilepsy and hydrocele surgeries?
Yeah, it's not relevant. Okay. So,
Okay.
if you want to mention the things which are relevant to you, supposedly the patient is had history of tuberculosis in like past, so that is important.
Okay.
Diabetes, hypertension, that is important. COPD is important because these things can change the course of the treatment per se, right? But this epilepsy, asthma, hydrocele, I don't think that is important. That will unnecessarily lead to some unexpected questions.
Okay, done, sir.
Move to the next slide.
Sir. Personal history. Patient takes mixed diet. He has normal bowel and bladder habits. He has normal appetite and normal sleep. He is a known smoker since 22 years. Takes one packet BD per day. He is a known alcoholic since 15 years. Takes local liquor occasionally twice a week. Family history. There is no significant family history. They come from a low socio-economic status. Treatment history. Patient has taken intermittent medication for this year symptoms only, including oral medication and topical ear drops. General examination.
Let me stop you till here. After giving the treatment history, you can put 3-4 lines about summary. That till history, what is your summary? Then move ahead to the examination part. Okay?
Okay, understood.
Now please let me know that what is fluctuant hearing. Till now, in what cases do you see this fluctuant hearing loss?
Fluctuant hearing loss can be seen in labyrinthitis, in menial disease.
Anything else? Do you remember?
Fluctuants are...
superior semicircular canal dehiscence.
Sir. Yes, sir.
Then third will be your active phase of CM mucosal. Okay?
Okay, sir.
Okay.
Active phase of CM mucosal.
Okay, till now, please let me know. You have taken history from the patient. Okay? You have taken history from the patient. While taking history, what do you think? There is hearing loss which he is having. Is it conductive or is it sensorineural hearing loss? And why? So basically, can you differentiate while talking to the patient? While talking, that is only while the history taking, that you said that this person is hard of hearing since last 6 months, 1 year, something like that.
Yes,
so while talking, what do you feel? This person is having SNHL or conductive? And why?
Sir, I think it is conductive, sir.
Okay.
Sir, I'm saying other way around. SNHL cases will have to talk louder in noisy surroundings.
What is this phenomena called? Anybody else? Unmute and answer.
Oh, okay, sir.
Please repeat once again. I didn't get it.
Paracusis
Okay, this is auditory feedback. What is she saying is that when the person who is having SNHL, like if he's hearing loud, he is trying to speak loud. Okay, so that was I was asking. Like we might have miscommunication. Okay, so coming to the question which was asked, that while taking history, can you differentiate while the patient is having conductive or SNHL? So basically, what happens in SNHL, there is problem in the speech discrimination. Okay, so he is having a problem in understanding of speech.
Okay,
so what happens in SNHL, basically there is problem in discrimination and understanding. So therefore, like when person is speaking loudly, still that patient who is there, he is unable to hear normally. Okay, so they will give this history that whenever they are talking in a group, he is like unable to hear it. Now on the contrary, in the conductive hearing loss, what happens? The patient hears better in noisy surroundings. This is there in the conductive hearing loss. Okay? And please read about auditory feedback phenomena. Okay, so this was what I was speaking about. So move ahead. You should summarize your case something like that. Like this year-old, my patient, so-and-so year-old, came with complaints of hearing loss of this much duration and hard of hearing of this much duration. Okay?
Okay, sir.
Okay, got it. Chalo, move ahead.
General examination. Patient is conscious, coherent and cooperative. He is moderately built and nourished. He is febrile. Blood pressure is 120 by 70 mmHg in right arm in supine position. Sorry, in sitting position. I have written wrong. Sorry. In right arm in sitting position. Pulse rate is 85 beats per minute in right radial pulse, which is regular rate, volume and rhythm. Respiratory rate is 18 breaths per minute. Abdominal thoracic. I think, sir, I avoid these also, sir, as we have told earlier. Yes, sir.
Before starting with the systemic examination, please let us know what are the positive findings in a case of CM case that you will be looking on this general physical examination. Go back one slide.
Sir.
Yeah. In the general physical examination, what are the points? Basically, what are those positive points I would like to convince that you should be looking for the CM case? Can you enumerate something?
Sir, if temperature is febrile, means we have to go for impending intracranial complications, meningitis, intracranial abscess.
So you are saying about fever. Okay.
Yes, sir. Fever, sir. If in case
of temperature over here, whatever you have written, temperature nahi hai. Abhi move to the next point.
In blood pressure, I have no points, sir. Pulse rate, I remember if it is Brady, it might be a brain abscess case, sir.
Lovely. What are the stages of brain abscess?
Stages of brain abscess, sir.
Okay, note down this point, read it.
Yes, sir.
Okay?
Yes,
and share it in the group for the benefit of everyone. Note this point.
Yes, sir.
Okay? So everybody, pulse, when somebody asks you what is the importance of pulse, it is important that bradycardia is seen in COM complication, whatever she said. This is seen in brain abscess. Okay? Stages of brain abscess you should know. So something else in general examination?
Sir, I didn't mention the pallor ictus sinuses clubbing.
So not tell me why is pallor important. So you are getting one point which you skipped. Okay? So make this as your important point. Now tell me why is pallor important and where is it seen?
Sir, pallor is important one for lateral sinus thrombosis, sir.
Okay, what is lateral sinus thrombophlebitis?
Lateral sinus thrombophlebitis is nothing but
Yeah. What kind of you are speaking that word? That word only I want you to utter.
Sir,
there is consumptive coagulopathy. This is the word that you have to say. Okay? And there is prothrombotic tendency. These are the two exact terminology which you have to say. I'll repeat for everybody. Consumptive coagulopathy and prothrombotic tendency. Okay? Other questions from lateral sinus thrombophlebitis are that it has picket fence fever. And what sign is seen specifically in LST?
Grissinger's sign, sir.
One more. Grissinger's sign is there. Okay. So
delta sign.
Delta sign. Okay. So remember the delta sign. That is the individual of key. One more thing you uttered. Grissinger's sign. What is Grissinger's sign?
Sir, greenish discoloration of the mastoid process along with swelling due to mastoid emission vein thrombosis.
Where is it seen? Which place?
Lateral sign.
Over what place? Over mastoid. Edema and tenderness over the mastoid and bluish discoloration of the post-auricular region, basically of the mastoid region. That's my point. Okay. Now, will it be more common in our part of country, like Indian setup?
No, sir.
Commonly seen.
It doesn't.
Why?
Low socioeconomic అంటే more impending to complications, more prone.
No. What I was saying is, I think you didn't get my question. Like supposedly there's a person who is from US and there is a person who is from India. Okay, so in which person will this Grissinger sign be more obvious, more commonly seen? You got that? What I was asking?
Okay, sir. Because in them, sir, because they are more fair skinned.
Yeah.
So
okay. So in our setup, we tend to have more melanin as compared to the US and those counterparts. So in those people, like जो कि standard textbooks है, so they show those images in which the Grissinger sign is more commonly more obvious as compared to ours. Okay. So you told about fever, you told about pallor, you told about pulse. Anything else is important in GPA?
sir. Sir, under parallel, we can say if it patient for pre-op we can use it at a minimum.
Yeah, okay, yes, you got it right. Lateral sinus thrombophlebitis and also an anemia because it will lead to the healing process and all. Now, anything else? I'd like to mention one more point. Is lymphadenopathy important?
Sir, if post-auricular lymph nodes.
Okay, post-auricular lymphadenopathy seen in which places fever में दिखेगा?
नहीं sir.
No, because post-auricular lymphadenopathy is commonly seen in scalp infections. Okay.
Sir,
also in cases of otitis externa, if your sebum is associated with otitis externa or scalp infections, in those cases this post-auricular lymphadenopathy will be seen. Okay.
Okay.
Move ahead to your systemic examination.
Yes, sir. So respiratory system, bilateral air entry is present, no added sound. Cardiovascular system, S1, S2 plus heard. Per abdomen, soft and no organomegaly. CNS examination, high intellectual functions are normal. There is normal motor and sensory functions. No focal neurological deficits.
Cranial examination. No short forms to be used until you pass your exam. Okay, everywhere full form.
Okay, sir. Sir, cranial nerves actually my sir says to say except 8th nerve, sir, but whether it is safe or not to say.
You say it's like that only. Now what will happen is as soon as you will say cranial nerves are normal, the person will ask you which nerve is abnormal. So you should be ready with your answer. Okay? Sir, 8th nerve, this will be problematic. Okay. Now any other nerve which you will be looking at which might be at risk in the sebum cases?
Sir, 7th nerve, sir, because of facial palsy complications. Next, petrositis, 5th nerve, 6th nerve. Next,
in petrositis, which is more like at risk?
No, sir.
Okay. So, second question noted down. जो उसके बाद अपन ने brain abscess के बाद second thing is read about petrositis. Okay. Petrositis, Dorellos canal 2, and third is Michel's cave. Okay.
Sir.
Now please let me know which ganglion is there in Michel's cave.
Gasserin ganglion, sir.
Gasserin ganglion, great. And one more thing, please let me know. With like so all the three branches of your trigeminal nerve, they pass through it. Okay. So why is basically this first one is more affected? V1 जो है आपका V1 of trigeminal nerve, why is it more affected?
Because sir, where the petrositis happens, sir, in the Gasserin ganglion, it has 3 parts, sir. The ophthalmic branch will be in the Meckel's cave, while the maxillomandibular will come from rotundum and ovale, sir.
So this is your OSCE question also. They'll give you a CT scan finding in which foramen, rotundum and ovale is visible, and they'll ask you what is coming out through these things. One. Second question is this this ophthalmic division. You answered it correctly that this ophthalmic division of trigeminal nerve, this is basically in contact with the Gasserin ganglion. So therefore the inflammation is passed to it and therefore the patient is having a deep retroorbital pain. Okay. Now please let me know if the patient is having 6th nerve palsy, what will be the presentation? What will you see in that patient?
Sir, lateral rectus palsy, diplopia, sir.
Great. Now what is Gradineau syndrome?
In petrous epicytis, which is a sebum complication, we see retroorbital pain, lateral rectus diplopia, and ear discharge.
Ear discharge. There is one word used before ear discharge, specifically used for this. Yeah, it is perpetual or relentless ear discharge. Okay, sir. So this is the word which you should use. Okay, so we got it till over here. Now third question, please add in your list. That is your named approaches to petrositis. You should be ready with the named approaches to petrositis, which are the hearing sacrificing approaches and hearing saving approaches. ठीक है?
Okay.
चलो,
Okay.
so moving ahead with your coming to the next part, please move ahead.
Yes, sir. Sir, the ENT examination, ear examination, sir, one doubt, sir, whether we have to say first the clear ear, then we have to say the diseased ear, or we have to just go first right everything, then left everything.
See, routinely what happens ki this is our routine practice, na? Right, we write first and then we go for the left one. Okay?
Sir.
So when write it this way only that you have written. Now when you are presenting it, then it's your wish. You can say ki sir, I am giving the finding of the normal ear first and the diseased ear on the second part. You should speak it. Okay?
Okay.
Nobody is so harsh that they will screw you for this. Okay? Speak it and then start answering.
Okay, sir. Okay, sir.
Okay. Let me know what is this.
Then the normal ear, that is left ear, I like to say the findings first. Preauricular region is normal, pinna is normal, postauricular region is normal, and extra-auditory canal is normal. On the right side, preauricular region is normal, pinna is normal, postauricular region is normal. In the extra-auditory canal, greenish color discharge remnants were seen.
What all problem like you can find in the preauricular region?
Sir, preauricular sinus, preauricular tags.
Okay, ठीक. Next is pinna. What is the normal position of pinna?
Normal position. Sir, it is attached to the skull on the either side with 15 degree
15 to 20 degree angle. Okay.
Superior is on par with the upper eyebrow, the supraorbital region, and inferior part is in the par with the ala of the nose.
Ala of the nose. Great. Very good. Chalo. Post-auricular region mein, you should be ready to answer all the questions about mastoiditis. What is the ironed out appearance? Okay. And what is the appearance of pinna in mastoiditis and posterior wall furuncle. Now coming to external auditory canal. Now what you are seeing is greenish color discharge remnant parts. Anything else you can answer in external auditory canal? Anything else that you can see?
Nothing, sir.
Okay. Do you know anything about lux abscess?
Yes, sir. Subperiosteal abscess, sir, which will cause the posterior wall sagging.
Okay. So that can be a finding which can be seen in the external auditory canal. Okay. Now second point is, do you like can you appreciate posterior canal erosion on otoscopy?
In this case, no, sir, we can't appreciate.
What is the importance of this posterior canal or deep canal wall erosion?
Because it is the posterior canal bridging between the mastoid antrum and medial
What is the importance? Clinical importance. Management में क्या फर्क पड़ेगा उसका?
Mastoiditis, sir.
Okay. See, if there is deep canal wall erosion, these patients you can go directly for canal wall down. It's already eroded. Okay.
Okay, sir.
Okay. Now, how will you check mastoid tenderness?
There's 3 finger test, sir.
Okay,
We'll keep our index finger over the tragus, over the simba concha.
I think you are थोड़ा fumble करो. बताओ फिर से please say again. Index finger there, middle finger there, thumb there.
Yes, sir. Index finger in the simba concha, middle finger in the mastoid region, posterior part of mastoid region, and ring finger in the tip of the mastoid region.
Please एक बार दोबारा से इसको you have to read it. As far as I remember, index is towards the posterior border of the mastoid, middle is your simba concha, and thumb is over the mastoid tip. But check it once again. Write it in that. Point is this. Okay. So moving ahead to the next part.
Yes, sir. So tympanic membrane on the right side, we can see pars tensa is dull and nasal.
Use your arrow. Can you use your pointer or arrow?
Sir, I actually don't know, sir, how to. I'll see, sir, once.
In case it's possible, just have a look. Take a second place. In case something is there, like with which you can point it out. Anything star point, कुछ भी. नहीं तो कोई बात नहीं.
उन्ने ना सिस्टम.
कोई बात नहीं. ठीक है. चलो, like this only you can proceed.
No, sir, not able to
not an issue.
anything, sir.
Not an issue.
Okay.
In the exam, see over here, I'll just brief you a bit, 30 seconds. When you will go with this thing in your exam now, so the examiner will be knowing the findings, what is the finding, but you don't have to, there is no endoscopic picture. Generally, they don't keep it unless until you are in some high-end center where they display the endoscopic picture over there. Okay?
Okay, sir.
So, this won't be much of an issue. And second will be, you should draw the diagram of your tympanic membrane in the answer sheet which you are carrying. Okay, don't treat that paper as a rough paper. You scribble it something over here and go to the exam. There might be, if the examiner might say, give your paper to me and then start speaking. So if you have drawn some fancy things over there, then you will be in trouble. Okay, so let's start with your description of this tympanic membrane.
Okay, sir. So, right tympanic membrane is past tense part is dull and lusterless. Handle of Malleus appears to be congested. Past placida part, there is a grade 3 retraction.
What is the name of retraction of past placida?
Past classification, sir.
What is described, Oscar?
Sir, grade 1 is attic dimple. Grade 2 is retraction of attic past placida touching the handle of Malleus, touching the Malleus, and grade 3 is partial scutum erosion. Grade 4 complete scutum erosion.
Okay. Now please write this thing also in that list. Okay, what you are taking down. Grades of both TOS and SADIC retraction grade. This should be on your tip. Okay.
Okay, sir. Okay.
Now last point.
This left tympanic membrane.
No. Last point got left. There's one very important question from this thing. You are saying partial erosion of scutum.
Yes, sir.
You're saying it, huh? Scutum is eroded. So scutum erosion is, please let us know, is this a finding on your endoscopy, otoscopy, or on radiology?
Oh, sir, endoscopy, sir. Now I have endoscopically seen, sir.
Normally, scutum erosion is the first sign of erosion on your CT scan. Okay, radiology basically. Okay, now please let us know, why is this scutum eroded? Erode क्यों होता है scutum?
Because it is the outermost attic wall, most common site for retraction pocket.
So take the name of Prozac space over here. ठीक है? Prozac space is basically the first place where the cholestodoma is generally formed. Now this is basically in contact with the scutum, and in scutum all the debris which gets deposited, the pH is basically the acidic, है ना? And second thing what happens that there is no annulus over here, so it is in direct contact with the bone. So there is erosion which is commonly seen over here. Okay, so please read about this thing on scutum. Now one more point over here only, like since you described the endoscopic finding with a picture, so whenever you are describing, if possible, you should use a pointer or cursor to point out whatever you are seeing. One. Second thing is always start with the normal landmark, which whatever you are appreciating. Sir, this is the anterior malleolar fold. This is the posterior malleolar fold. Whatever you are able to see. Okay. Then this is the handle of Malleus, which appears foreshortened, which appears congested. Whatever you want to say.
Okay.
This is the cone of light, whether it's appreciated, whether it's not appreciated. Then you should come to the, sir, this part is pars tensa, which is retracted. Now he will ask you, what is the rating of pars tensa retraction? Sir, this part is pars flaccida. Then, sir, this part is pars, this is the retraction pocket which is seen. Getting my point? So you should start from the normal landmarks and then go to the entire disease. Supposedly you get a patient in which there is a perforation. So directly don't jump upon, sir, there is a perforation in the moderate perforation in these quadrants. Describe this, okay?
Okay,
move
sir.
to the next examination part.
Okay, sir. Sir, shall I repeat this, sir? And according to what you said now?
No, it's not according to me. See, go whatever you have been taught in your institution. My main point is, it's like you should be able to answer fluently in the exam. That's it. I'm not aiming towards all the questions academic excellence, only towards Viva and passing the exam. Repeat it once again, not an issue.
So, past tense part is dull and lusterless, with the handle of Malleus appears to be congested. Cone of light is absent. In past placida, we can see a grade 3 retraction with partial erosion of scutum.
ठीक है. चलो आगे चलिए.
Left tympanic membrane, sir. So this I wanted to ask you sir once. And if the मतलब examiner लोग आके check करते हैं क्या sir? And this is attic retraction is there no sir?
Normally what happens कि whosoever is coming in the exam, your internal examiner, your department people will also be there. Okay, so they would have already given him the findings. What is the finding in this patient? Okay. So second thing is कि nobody is interested in screwing you over one thing which you have missed. It's like they want to justify what technique you should follow once you pass the exam. ठीक है? All these things are highly immaterial. Believe me, once you go for the exam, you'll realize it. All these things are immaterial. It's just to complete it. Like you should know. Okay. And one or two odd findings you're likely to miss. It's not that you will know 100% of the findings. So don't worry. Even if you miss one or two findings, whether it is attic dimpling or whether it is draped over it, you shouldn't just एकदम clueless नहीं होना चाहिए. कि you shouldn't be exactly clueless about what's happening. You should go about whatever moderate findings you can see, and your questions will be based on whatever you are saying. Okay.
Understood.
Now, describe whatever you are saying.
So left tympanic membrane. Here pars tensa is dull and lusterless with mild condition.
Start with the landmarks. Sir, this is the anterior malleolus fold, this is the posterior malleolus fold, this is handle of malleus, this is cone of light. Now come to the pars tensa, then go to pars flaccida, and then go to whatever findings you have. Okay?
Okay, sir. Okay, sir.
Okay.
Anterior malleolus fold, posterior malleolus fold. Okay, sir. Next, tuning foot test, sir. Sorry, this actually I thought of mentioning above, sir. Here it came, sir. Okay. Refungal test is negative, sir, on both the sides, sir. Tragal tenderness is negative on both the sides. Facial is intact on both the sides. Next, balance test. Sir, I think I missed. Sir, sorry, sir. Tuning fork test. Release is on 256 hertz. It is negative on right side and positive on left side. 512 hertz is negative on right side and positive on left side. 1024 is positive on both the sides. Weber's is lateralized to right side. Absolute bone conduction test is same. Sir.
Is it possible that 256 is negative in right and 1024 is positive? ऐसा हो सकता है?
Under 256.
Yeah. What does this mean? 256 hertz is positive in right. What does it mean? How much hearing loss is it there?
15 to 30 decibel loss, sir.
15. ठीक है? 30 15. ठीक है? So if one is negative, all three will be negative. Okay?
Okay, sir. Okay.
Now, what is this Weber's you are saying? Okay, lateralized to the right. Okay. Is it corroborating? Okay. Now tell me, which is more sensitive, Rennie's or Weber's?
Weber's, sir.
Why?
Because it's minimum, it can, what to say, 5 to 7 decibels, it can take up, sir. It can lateralize by even differential 5 to 7 decibels. While release minimum, it requires 10 to 15 decibels.
ठीक है. Read about this modes of bone conduction, modes of air conduction. ठीक है? It can be also asked. Okay. Now please let me know at what age, like your person is, कितना age है आपके patient का?
38, sir.
38. So at what age does a person you can say that PTH will be okay? This Rennie's and Weber's will be okay?
5 to 7 years, sir.
5 to 7. Okay. Great. Move to the next slide.
Yes, sir. Balance test, sir.
What is it? Fistula on negative sides. Fistula test is very important question. Please everybody note it down. It's an important question on Oski spotter also. It's an important Viva point question also. And how you should approach it, I'll just explain it to you. In these type of questions, you should speak what is the principle behind the fistula test. 1. Second, you should speak how you should elicit the fistula sign. 2. And then you should go on what is the interpretation of fistula test. Getting my point? It's not that you just, sir, your examiner asks you what is fistula test. You say, sir, we press on the tragus of the patient and then there is nystagmus. So this should not be the answer. So if you go in a streamlined format, sir, this is the principle. How you will go about, sir, we will give alternate compressions over the tragus with our finger. Approx, we can use the Siegel speculum also. And then you should go about the finding what is the false positive, false negative. That gives a better impression on the examiner. Okay. चलो move ahead. You said gaze, you said rhombus, you said cerebellar.
Yes, sir.
Okay. ठीक है, चलो move ahead. Anything else you have to say?
It's a probable diagnosis, sir.
हाँ.
So there's a 38-year-old male with ear discharge since 1 year and hard of hearing since 6 months.
No, you here directly.
Probably. Acha, sir. No summary.
38-year-old male with case of you can speak. Not an issue. Let the examiner tell you. Don't say. Okay. From your point, you should say.
Okay.
Don't take anything unturned. Okay. Speak.
Okay.
What diagnosis you want to say?
With right active type of squamous type of chronic otitis media with moderate conductive hearing loss. So, if we remove tinnitus, then I'll remove this probable labyrinthitis also.
Exactly. That's my point. Okay? You will be digging your grave by speaking about labyrinthitis and tinnitus. So your entire viva ka like that thing will shift from your main focus. Okay? Now over here 2-3 questions will be there even if you remove your this labyrinthitis. One thing is that why do you say it is active? What is the difference between active squamous and inactive squamous?
Sir, active due to still ear discharge is continuously occurring.
Squamous में क्या दिक्कत होती है? There is difference between active of squamous and active of mucosal. Can somebody take a try?
So just a retraction pocket which is dry, it is inactive. But retraction pocket with the debris or cholesteatoma.
Yes. So in squamous or articoenteral type of disease, if there is presence of cholesteatoma, that is active squamous. And if there is no cholesteatoma flakes, no debris, no retraction pocket, that is an inactive squamous. Now please let us know what is active mucosal type.
The first discharge is there.
Exactly. When there is pus or discharge coming from middle ear, that is active mucosal, and otherwise this is inactive mucosal. And there is one more fifth type of cm which is Scott Brown mentions is cm healed. Okay, 5 प्रकार का है. Please remember the difference. Okay, so you are saying right active squamous type of chronic otitis media with moderate conductive hearing loss with probable labyrinthitis. अच्छा, labyrinthitis why you have included? Because you said tinnitus along with it.
Yes, sir.
Okay, so my take it, like if I would be giving the exam, how I will present it, this is chronic otitis media, right? So how I will present is, sir, this is chronic otitis media, right side with active squamous disease with moderate conductive hearing loss without any impending complications. Okay, now wait for the examiner that how he wants to take the viva to the next level. Now anything else you have to say after this?
Investigation.
Okay, so your case will not be completed until you say the examination of your nose also.
Yes, sir.
So you have to mention whether there is any DNS, whether there is any adenoid hypertrophy, all these things also you have to mention. If there is any positive thing, as you can say, sir, nose examination is within normal limits. That is okay. So I will ask you, what is the positive findings you want to look in the nose? Can you name something?
Sir, deviated nasal septum towards next adenoids, sir.
But so we have to basically look at the nasopharynx, na? Isn't something going wrong with your eustachian tube? Okay, so Dr. Saab, you complete your presentation till now. Please let us know how you will proceed with the case. Now this patient has come to you. You are a practicing ENT consultant in a hospital or a private setup. How will you go ahead with this case?
Then I'll send ear discharge oral swab for culture and sensitivity.
First opening statement should be, sir, I will like to investigate the case for further management. And after that, I will like to counsel the patient for surgery. Now he will ask you what investigations you would like to take.
Okay, sir.
Batao.
Oral swab for culture and sensitivity. Examination under microscopy.
Examination under microscopy for what? What we should be the aiming at?
To know the retraction pocket or what is the extent till it is there, sir. And to remove any debris there. For any oral toilet figure.
Okay, good.
Culture.
After this microscopy, what you will do?
Then we'll send for HRCT temporal bone, sir.
Directly HRCT. पहले कुछ और करा?
X-ray mastoids we can say, sir.
See, this is basically, I'll say, a type of dichotomy question. ठीक है? You might even get screwed if you say X-ray. They might shout कि in this era 2025 still you are stuck with X-ray. Why you will not go for CT? Or if you directly go for CT, they might say that people are very poor. There is no CT available in few tier 3 cities. Why you are directly going for CT? So don't worry. This can come. So you should start with X-ray and then go to CT. Okay?
Done, sir.
Before CT, you should speak about PTA. ठीक है कि सर मैं PTA करेगा इसका. Now PTA नहीं, pure tone audiometry बोलना. Now why you will do PTA? What should be your aim?
To know the hearing loss quantity, to know the quality of hearing loss, for documentation purposes.
Documentation and medical legal purpose. Great.
Medical legal.
Now you are doing. Sorry, you are going to do the HRCT scan of the patient. Okay. So what you will be looking at the HRCT scan?
To know the actual anatomy, sir, if there is any low-lying dura, anterior placed sigmoid sinus, facial anatomy, any dehiscence, anything. To know the cholesteatoma, if any disease, how much it is extent of the disease, sir. Next.
Okay. Now please let us know. Normally what happens ki everybody goes for CT only. Are there any specific indication for CT? Like supposedly you are a doctor who relies on his skills. Ki, I will go ahead and I will find it on table and do it. What are the specific indication that इसमें without CT you will not proceed forward? Any indication do you know?
Intracranial complications, any symptoms impeding to intracranial complications?
Any complication you will do CT before proceeding. Anything else apart from this?
The VIP patient, sir.
VIP patient, yeah, that is also an answer. So VIP patient will not go to a place which doesn't have a C, which the doctor is commonly doing X-ray, है ना? आजकल सब कोई कर रहा है. And it's a correct answer, but they should come lower the precedence. Okay. Anything else? Apart from your complication, revision surgery, you should say, sir, if there is any congenital anomaly or if we are operating the only hearing aid. ठीक है? And then Dr. Divya added a VIP patient also. That clause also you can use. That's also a good thing. Okay. PT आपने कर लिया. Then what kind of surgery will you advise to the patient?
In this case, we'll advise for canal wall up mastectomy, sir.
Okay.
And cortical mastectomy, sir. Yes, sir.
Canal wall of mastectomy and cortical mastectomy.
Sorry, sir. Canal wall up, sir.
Don't worry. No, not an issue. See, all the apprehensions are basically everyone has these things for exam. Okay, I'm able to speak confidently because I'm on this side. अभी मेरा exam हो गया. That's why I'm able to say कि भैया ऐसे don't do this thing, don't do that thing. But it is there with everybody. Don't worry. Okay, so the thing is try to basically these are the very stat questions. Okay, so you should be ready with the answer. Okay, sir, I would like to go with this type of surgery. Okay, so now here only they will ask you कि भैया why do you want to go with canal wall up? What are the indications of canal wall up? What is the advantages of canal wall up? Be ready with this answer. Okay, for this you should see everybody has its own how they were taught in the institution, like how we were taught and how I have been going since last 5 years. Sir, I will like to proceed with canal wall down mastectomy for this patient. So I will ask you why canal wall down. So how we were taught is कि sir, with my experience, like you are fresh from PG, okay, hardly people get to operate squamous case or canal wall down. Only few centers are there where they give hands-on over there. Okay, so you can say, sir, with my experience, I would like to gain more exposure and try to eliminate the disease completely so that there is no recurrence of the disease for the patient. Okay, then same questions will come again to you, that what are the indications of canal wall down, what are the advantages of canal wall down, what are the disadvantages of canal wall down. Getting my point? Okay, now the same question of your that cavity ka question, every time they are going to ask you what is the ideal cavity. Do you know something?
Ideal cavity is where the lower level of extraordinary canal is on par with the lower level of the saucerized part, so that there is no reservoir effect or any something, sir.
Good.
And it should be some depth is there, sir. उतना ही याद आ रहा है, sir.
चलो ठीक है, go ahead with that जो 20 pages का article है ना, it contains 5 points for this ideal cavity. ठीक है, so this should go. ठीक है, and anything else you will counsel the patient before surgery?
For all the complications, sir. Facial complications, dural this, and he may even land up in complete loss of hearing, sir.
Okay, that you have to counsel the patient.
Yes,
that
sir.
you have to counsel the patient. Now, please let us know that you have told that the type of surgery that you will perform, all these things are there. Now, from here, the things will go on discussion for your cholestoma. Okay, they might even start from as basic question as definition of cholestoma. They might start or ask you what are the theories of cholestoma. So you shouldn't get stuck with that question. Okay, so my humble request is, if you have not read about these things, please go through that. Okay, now please let us know that why is this cholestoma common in the posterior superior quadrant of tympanic membrane? Do you have any explanation for that?
It is a less ventilated area, sir.
Yeah.
And next, when compared, the fibers, when compared, the distance between the fibers from hand of malleus to annulus is more nearer when compared to that of distance between hand of malleus to posterior part of the annulus. So it has become more flaccid and more prone for retraction pockets, and then more prone for this.
Okay. Two more things which you can add is, one thing that the ossicles are basically just behind the tympanic membrane in the posterior superior quadrant. So therefore, even if like smallest amount of retraction is there on the tympanic membrane, so it will adhere to the ossicles, and chances of cholestoma formation will be higher. Okay. Now, sixth question, please write it down. What is the boundaries of Prozac space? It should be on your tips, everybody. ठीक है, हर बार पूछते हैं ये क्वेश्चन, प्लीज डोंट फॉरगेट इट. ठीक है, हाउ द cholestoma travels from one quadrant to another, so you should be like well versed with the mucosal folds. ठीक है, that is beyond the imperative, beyond the discussion of this topic. It is important. ठीक है, it can be asked as an OSCE also, that how this is ventilation, anterior wall, posterior wall pouch, all these things you should be like ready with that. Okay, now please let us know, do you know any abscesses which are there in relation to ears? Any named abscess?
It is extratemporal complication leading to City's abscess, Bisol's abscess, Lux abscess, these three named abscesses. Others are.
You should remember them. Remember their location, and apart from that, you should remember that from where they are originating. Okay, good. Now the question can, like, you have counseled that this surgery can take place. Okay, so you told about what you will look in CT is the dura. You told about the carotid. You told about sigmoid sinus. You told about facial. One more thing you can say that we will look how is the labyrinth, how is the jugular bulb. That I was telling you that time. Okay. What is the high jugular bulb? So that you should remember that criteria for high jugular bulb. Okay. Now the question can rise. They can ask you about all the steps of surgery, how you will go with. They might ask you the whole cortical also. They might ask you that routine tympanoplasty questions. That what is the Weil's incision, what is Lempert's incision. This can go till that level. Okay. Okay. Now we have around 10 minutes of time. Okay. So what kind of what are the boundaries of sinus tympani? And why is it important in this case?
Medially promontory, laterally facial canal, superiorly ponticulus, inferiorly subiculum. It is important in this case because it is one of the hidden areas in the cholestoma.
Good. Yes. Good. And now, would you like to predict how would be the surgery? Aapka surgery kaisa hoga? Are there any factors, any scoring which is available that you can say that this will be the outcome of the result?
Many risk scores.
Many, okay. So this is like I used it, middle ear risk index. Whenever I gave the findings of the inner ear, I purposefully had repeated what is Mary's index over there. So the examiner will ask you what is Mary's index? Why do you include it over here? So you should be ready with your answer. That sir, this is the exact details of Mary's index. This is why we are asking. Okay, this will be the outcome which is there. Okay, what is Belfast rule of thumb? Note it down. देख लो. ठीक है, important question है. Belfast rule of thumb. It will be asked. Mary's is important. It will be asked. Second, third question is types of tympanoplasty. Okay, so be ready with TOS. Be ready with Wolstein. At least two you should remember. ठीक है. obviously वो भी रखना याद रखना है. I know these are the basic type ना, type 1, 2, 3, 4, 5. But what happens is that in that stress type of performance, you are likely to forget the answer. ठीक है? Getting my point? Okay. And apart from that, one routine question is there. What is the indication of cortical mastectomy? Okay. So basically speaking, there is like 2-3 things which you can answer. One is the persistent mucosal disease. Second is colicin mastocytosis. That is a specific question. So इसमें what you have to answer is colicin mastocytosis. And third is any complication of like acute mastocytosis. In those cases, cortical mastectomy will be attached with the main surgery. Okay. Then your fistula test is that. Please write it. This is very important. This can be asked in OSCE, Potter, Table, simple routine question, and in your main theorem commerce, it is definitely gonna be asked. Okay, so you should remember what is false positive fistula कहाँ पे देखने को मिलता है, false negative fistula कहाँ पे मिलता है. That is equally important. Okay, and what are the methods of performing the fistula test? Please read about it. In case you get stuck anywhere, please let me know. Okay, so this was one of the I'll say routine basic type of thing. Please go through. Till now I have shared 3 videos of Theorem Commerce. What I believe is please go through those videos. All these videos are basically, in those videos, the examiners are basically the India के standard examiners हैं. ठीक है? So you will be getting the questions which are standardly asked in the MS exam and in the DNB exam. Okay, all these three videos are shared. Please go through them. One is from the अपने यहाँ का southern part का है, जो अपने ये अपना CMC के सर हैं उनका है, and 2 are from the Haryana Council and Delhi के जो अपने MMC के सर हैं उनका है. So basically it gives you a mix of teachers who are asking the questions. I have taken today's all questions, whatever I was remembering it, plus 3 videos I have seen it multiple number of times. I should not miss any basic question which will be asked to you. Okay, now if you have any point, please let me know. Okay, now otherwise from next class onwards, what I've planned is every starting 10 minutes, 15 minutes, we'll discuss around 10 OSCEs which have been previously asked, so that it will boost up your confidence. Then we'll discuss a small surgery every time, because generally what there is one OSCE every time on surgery what is being performed. So there are hardly I'll say 10 to 15 procedures which are important for the exam purpose. So in every class we'll discuss 2-3 of them and we'll finish it off. Okay, and anything from your point, please drop a text message. Okay, any positive or negative comment, please drop it. And now it's high time, I'll say. Hardly 3 weeks are left. आखिरी हफ्ते किसी की पढ़ाई नहीं होती है. Nobody reads on the last week. We all are under pressure and stress. So these 2 weeks, give your maximum. Take care of health. Don't fall sick. If you fall sick, everything is gonna be ruined. Okay, so that is very important. Take good care of your health. And any problem, I'll say, na, you get